Hi, welcome to our Genetics and Hearing Loss, Pack Your Bag, Find Your Path, Start Your Journey talk with Amanda Schaefer. She's a genetic counselor from the University of Iowa Hospitals and Clinics. And she does have some disclosures. Her disclosure can be referenced at the bottom of your screen. She's employed by the molecular otolaryngology and renal research laboratories, a nonprofit genetic testing laboratory that provides fee-for-service genetic testing for hearing loss. Please also see your screen for continuing education information, accreditation information, and your learning objectives for this talk. Her key learning objectives are describe key components of genetic evaluation for hearing loss and list red flags to identify in medical history, family history, and physical exam, access potential benefits, risks, and limitations of genetic testing for hearing loss and impact on patient family decision-making. So I'd like to hand it over to Amanda. Thank you.
Thanks so much, Stephanie, or excuse me, Jamie, for that introduction. I'm so excited to be joining you all today. And give me just one moment while I check my display. Excellent. Well, I'm so excited to be joining you and sharing some of my area of interest, which is the genetics of hearing loss. And you've heard from Jamie about my disclosures, which I'm showing here again. As we go through the talk today, I just want to start by offering some key definitions for you that are relevant to the talk and the patient population we'll be discussing. And these key terms are to differentiate between the capital D deaf and our lowercase d deaf. With the capital D deaf, I'm referring to a distinct cultural community that uses sign language, and their experiences are shaped by being deaf or hard of hearing. And this can include individuals who are deaf, hard of hearing, or hearing. Members of the cultural deaf community, it's important to know that they don't view their deafness as a handicap, an impairment, or something that should be prevented, cured. Rather, they see their deafness as just a part of themselves and their identity. In contrast, when we use the lowercase d deaf, we're talking about an auditory phenotype characterized by the total or near total loss of the ability to hear. I'll also use the phrase hard of hearing, or HOH, to talk about the auditory phenotype of a partial loss of the ability to hear. With those terms defined, let's get started. The first part of today's talk is really just to provide some background information for you all about hearing, hearing loss, and what role genetics plays within this area. So for those who maybe don't have a lot of knowledge about hearing loss, I'm showing an ear and the outer, middle, and inner ear components, just to help to define ways that we can talk about hearing and hearing loss. And the way we hear, if you don't recall from your biology classes, sounds enter our outer ear, they travel through the ear canal, where those sound waves hit our eardrum or tympanic membrane. That then moves your middle ear bones that are shown here in your middle ear. That sound wave is transmitted to your inner ear, where your cochlea, or this kind of snail-shaped piece, are located. That sound wave is then changed over into an electrical signal that transmits to your hearing nerve, your cranial nerve, where it's taken to the brain and interpreted as sound. There's a lot of different ways that we can describe hearing loss in particular, and I've shown a couple of ways on this slide here. One is to talk about what type of hearing loss someone has. This could include a conductive loss, where there could be an issue with the outer or middle ear, a sensory neural issue, or hearing loss where there's some type of process not working within the inner ear, and some Another type is called auditory neuropathy, where there's either a message not making it to the auditory nerve or not making it from the nerve to the brain to be interpreted as sound. Another way we can categorize hearing loss is by the onset or when that hearing loss starts. Hearing loss can be congenital or present from birth. Prelingual, meaning it occurs or starts before someone learns to speak, or postlingual, after someone learns to speak. You can also see terms like bilateral, meaning hearing loss in both ears, or unilateral, hearing loss in one ear. Other information we can use to describe hearing loss include the severity of the hearing loss and maybe the frequencies of sound that are impacted by that loss. When hearing tests are done, they're measuring two different components of hearing, and those are the loudness of a sound. So they'll play soft to louder sounds, and then the pitch or frequency of that sound. So low sounds like tuba up to higher pitch sounds like a bird whistling in a tree. And when they do these tests, they make what's called an audiogram, which is a graph of those data, and can use adjectives to describe the severity of the hearing loss. So you might see things like mild, moderate, moderately severe, etc. So they'll play those different loudnesses of sounds and different pitch, and then graph it out in what's called an audiogram. And here I'm showing you someone who has normal hearing in both ears, as shown by the circles and X's, in comparison to this audiogram, where the individual has a bilateral profound hearing loss. Interestingly, we can also see differences then when we look at these audiograms in something called the audio profile, which is a way of saying what's the degree or severity and what frequencies of sound are impacted. And they can often fall into different patterns or audio profiles. And I'm showing you 3 examples here that we can see with different types of genetic hearing loss. On the left, you can see a low frequency hearing loss due to the gene WFS1. In the middle, a downsloping hearing loss, where hearing loss is worse at higher sounds than lower sounds with the gene USH2A. And then a fun one on the right, what we can call a cookie bite or mid-frequency, where individuals' hearing is best at low and high sounds and not as good in mid-frequency sounds. So we can use all of this information about someone's hearing loss to describe and hopefully correlate to genetic causes. It's important for you all to know and recognize that hearing loss in itself is something that's pretty common. In the United States, they estimate about 1 in 500 newborns have some degree of hearing loss. And the prevalence of hearing loss increases with age. Again, in the United States, we know from studies that about 15% or 1 in 7 of people over the age of 12 have some degree of hearing loss. Now, it is important to point out that not all hearing loss is genetic. There's a lot of different things that can cause someone to have hearing loss. These include things like the natural aging process, trauma or head injuries, the use of certain medications that can be harmful to the ear and hearing, and illnesses or infection. Of course, today we're going to talk primarily about those genetic causes of hearing loss. So if we look at the category of that prelingual hearing loss, so congenital or before someone learns to speak, that's about 1 in 500 people. And we split them into genetic causes and environmental or acquired causes. We can see that about 60 to 80% of the time, hearing loss has an underlying genetic cause to it. On the flip side, the acquired or environmental causes can include some things like we talked about on the previous slide, things like infection, people being born premature, or the use of certain medications. For hearing loss that has a genetic cause, we can further break it down into 2 categories, where the majority of hearing loss is non-syndromic, about 70% of the time, and about 30% of the time then hearing loss that's genetic is due to an underlying genetic syndrome. Now I'll point out on my flowchart here, I have data about prelingual hearing loss, I often get asked, well, what do we know about a postlingual or even an adult onset hearing loss? I don't have such nice flowcharts and numbers to share, but I will add that studies do indicate that for postlingual and adult onset hearing loss, a significant proportion are either caused by genetics or influenced by genetics. So I've shown you here that genetic hearing loss can fall into non-syndromic and syndromic forms. And I'll define those for you, much as I do for families that I work with in the clinic. That non-syndromic hearing loss means there's a change in someone's gene, and that change only causes someone to be deaf or hard of hearing. What's really interesting about hearing loss in general is there's a lot of genes that have been identified that can impact our hearing. At this point, we know of more than 125, and that number continues to grow. Syndromic hearing loss, on the flip side of things, is when there's a change in a gene, it causes someone to be deaf or hard of hearing, and that gene change also affects other parts of the body. And this could be either that gene impacts how those, maybe there's other medical conditions that go with that gene change that impact, say, the kidneys or the eyes. Sometimes this can even be physical differences that we can see in people. And again, much like non-syndromic hearing loss, where we see a huge number of genes, so too in our syndromic hearing loss category, we're up to more than 600 different genetic syndromes in which people can have hearing loss as a component. Hopefully you're not expecting me to go through all of the different genes and syndromes in which hearing loss plays a role. So I'll just kind of briefly describe some ways that we can start to break those into smaller pieces. And for non-syndromic hearing loss, there's a number of ways we can make categories for these genes. They include things like what's the age of onset, the severity of hearing loss, and those audio profiles we discussed earlier. And is the hearing loss predicted to be stable or progress over time? So in terms of stability or progression of hearing loss, knowing which gene is causing someone's hearing loss can allow us to provide information about what is expected over time. So on the slide here, I'm showing two different genes and audiograms of people who have that type of hearing loss. On the left, the gene stereosilin is known to cause a stable sensory neural hearing loss. In comparison, on the right, I'm showing a different gene, KCNQ4, where hearing loss is known to be progressive as someone ages. And you can see in this graph for individuals shown by these different lines, as someone ages from 20s, 40s, 60s, and older, we can see that the hearing loss does get worse or progresses. So knowing about which gene is causing hearing loss can help us as healthcare providers give that information back to families. Another way that we can characterize non-syndromic hearing loss genes is through inheritance, or knowing about how genetic hearing loss is passed on in families. And I'll say for most people who I talk about my job, that I'm a genetic counselor, people hear genetics and think, I know what that means. Maybe it's something that's passed on in the family. You have a family history of multiple people with the same condition, in this case, hearing loss. But you might also know this statistic that in the deaf and hard of hearing world, 90 to 95% of deaf and hard of hearing children are born to hearing parents. And what this reflects for us is when we look at inheritance patterns for hearing loss, most of the time, about 80% of the time, hearing loss that is genetic is in an autosomal recessive pattern. And I'll show you what that looks like on the next slide. There are other patterns of inheritance, like a dominant pattern of inheritance, where we're more likely to see things like, oh, it's being passed on generation to generation in our family. But given that most genetic hearing loss is in this autosomal recessive pattern, I just want to show you, talk through what that kind of looks like. This will be families you're working with. Maybe they have a deaf or hard of hearing child. Parents are both hearing. In a recessive pattern of inheritance, we have two copies of almost all of our genes. One's come from mom and one's come from dad. And in a recessive pattern, both copies of that gene need to not be functioning normally. And that is what's causing the hearing loss in that individual. In a recessive pattern, most of the time, again, we see that parents are hearing because they are a carrier of one working copy of the gene and one non-working copy. And by chance alone, if both of those carrier parents pass on that non-working copy, they can have a child who's deaf or hard of hearing. That's a 25% chance for each pregnancy. That also means by chance alone that they could have a 75% chance of that child being hearing. And the takeaway message for you all to remember is that genetics can still be involved in hearing loss with or without a family history. Let's just briefly turn our attention to some examples of syndromic hearing loss. And I'll use these three examples of Waardenburg syndrome, Usher syndrome, and Pendred syndrome. Waardenburg syndrome is a genetic syndrome that can present with hearing loss, as well as changes in pigmentary cells of the hair, skin, or eyes. So some examples of what this might look like, you can see this woman here, she's got brown hair, and she's got this patch of white hair at the front, something we call a white forelock. You can also see something called heterochromia in this condition, individuals who maybe have two completely different colored eyes or parts of their eyes are different colors. And in some types of Waardenburg, people will have eyes like this boy that appear a little bit more widely set maybe than other family members. The second syndrome that we'll go through is one called Usher. People who have Usher syndrome have hearing loss and also develop a progressive vision condition called retinitis pigmentosa or RP. The vision condition causes a progressive tunneling of the field of vision. What's challenging or interesting about Usher, for most of the subtypes, that progressive vision condition will start sometime in the first or second decade, but isn't present from birth. Not something that we know about when a child is born. But again, depending on the subtype, the most common causes of Usher syndrome have congenital hearing loss, something that we know about from birth. And the third syndrome, Pendred syndrome, individuals have most often congenital, bilateral, profound hearing loss. Some can present with balance issues, something they call vestibular dysfunction. And if individuals get a CT or MRI, there are some pretty characteristic differences or changes to the structure of the inner ear, called an enlarged vestibular aqueduct, or sometimes people have something called Mundini malformation. And I use these three syndromic examples just to illustrate not only the vast diversity in what we see presenting in these syndromes, but also to highlight that not all syndromic types of hearing loss have either a physical difference we'll notice from looking at someone or medical concerns that are present from when that hearing loss starts. So we might look at someone either in clinic or someone that we know and think, oh, they have hearing loss or deafness, and they could still have a genetic syndrome that explains why they have that hearing loss. So to wrap up kind of our quick introductory to genetics and hearing loss, we have talked about how genetic causes are the most common cause of childhood onset hearing loss, and genetics contributes to adult onset hearing loss as well. We've talked about the ways that genetic hearing loss is incredibly diverse in the way that it presents in individuals, and that genetics can play a role in hearing loss with or without a family history of hearing loss in other family members. So now let's start talking about, well, what is the what, when, where, and how of genetic services for deaf and hard of hearing persons? And an important thing for you all to be aware of and for providers to be aware of is a genetic evaluation for deaf and hard of hearing children is recommended by multiple organizations. And I've listed a few on the slide here, including the Joint Committee on Infant Hearing and the American College of Medical Genetics and Genomics. I'll point out too that the American College of Medical Genetics and Genomics also recommends an evaluation for adults with hearing loss, in particular when there's not an underlying cause that had been identified or pinpointed for those adults. There we go. So now, why might someone think about getting a genetic evaluation for hearing loss in particular? And we can put that into kind of three different bins of categories to think about. Those three bins being the medical care, family care, and social emotional care. Having a genetic evaluation and identifying a genetic cause for someone's hearing loss can help us provide information about what to expect for that hearing loss. So we had talked about, will hearing loss be stable or progressive? It can also help guide subsequent medical care for individuals. For example, if we identify a genetic syndrome as causing hearing loss, it can help guide, is there additional medical care or medical providers we should be adding to someone's care team? For family care, it can help us provide families information about the chance of hearing loss maybe in another family member or the chance of hearing loss in a future pregnancy for an individual. And on the social emotional care side, having that genetic evaluation can help to address maybe the emotional impact of learning about hearing loss or deafness in a person or their family member. It can help provide important connections to other deaf and hard of hearing people and families, and sometimes address misconceptions or misinformation that people have about maybe the cause of someone's deafness. So this could be things like, oh, when I was pregnant with this child who's deaf, I drank a particular kind of tea, and I think that's what's caused the hearing loss in my child. Um, So sometimes people ask, well, what does it exactly mean to have a genetic evaluation for hearing loss? And I put the pieces of the evaluation into four main bins: to gather information, to provide education on hearing loss and options for genetic testing, to help a family or person make a decision about certain things like should we get genetic testing, and to provide resources and support. So let's just briefly walk through the different pieces of that evaluation. And I'll highlight too, in our resources today, you'll get all of this information as well. So from a medical history standpoint, as providers, we want to ask about prenatal, birth, and neonatal history, as well as gather information about that hearing loss history, with our big question being, well, is there anything in this person's medical history that could explain why this person is deaf or hard of hearing? And turning to our family history, of no surprise, you want to ask if they have a family history of hearing loss. And in particular, you'll want to focus, well, does anyone have hearing loss similar to the person that you're evaluating? So we discussed maybe that aging is something that can cause hearing loss. So if you're meeting with the family who has a infant with hearing loss and they tell you about a grandparent who had hearing loss in their 70s, that may or may not be connected to what you're seeing in that child. And knowing about more common syndromes that can cause hearing loss, your family history should also screen for other conditions that could be related to the deafness or hearing loss. So things like kidney conditions, those features of Waardenburg that we discussed earlier. And finally, in your information gathering, you'll perform the physician will perform a physical exam. And I always tell parents it's not just about the ears in this case, although those ears will be looked at. But the physical exam should also look at the neck, skin, and face, eyes, and hair, for example. And we can think back to that slide on Waardenburg on why our physical exam for hearing loss doesn't stop with the ears. And I'll remind you again that a normal physical exam or not seeing something obvious in someone doesn't rule out that their hearing loss couldn't have an underlying syndromic cause. Okay, so to wrap up all that information gathering from the medical, family history, and physical exam, we're essentially asking you the question, does this person's history suggest that their hearing loss or deafness could be due to a genetic cause? If your answer is yes, I think that there could be a genetic cause to explain this person's hearing loss. And again, I'll just provide a brief overview of here's the basic steps for genetic testing. If that's something you're not familiar with, the first step is to gather the sample that you're going to test. Most of the time, that's a blood sample, but sometimes a cheek swab or saliva can be used. That sample is sent to a testing laboratory that then tests the DNA available in the sample. And this can differ by the test being ordered, the number of genes, what kind of technology, etc. They then will essentially do a spell check of that DNA sequence to look for any changes or genetic variants. And ultimately, it's interpreted and reported back to the provider to share with the person and their family. Again, probably a little outside of the scope of this talk, but what kind of genetic testing could be ordered for individuals to evaluate hearing loss? And at this point, they kind of fall into two large bins. Most often, a multi-gene panel for hearing loss to test all genes that we know play a role in hearing loss can be ordered. Although our recent recommendations also highlight the use of something called exome, where we test all genes that we know about at the same time. At this point, our recommendations are guided by what things are seen on a physical exam and medical history and family history. Um, for individuals that have findings on that physical exam that suggest some type of syndrome, more often an exome would be ordered. But for individuals who seem to have a non-syndromic hearing loss, that multi-gene panel is the recommended first choice. When that type of testing is done, there are three types of results that we can get from that testing. The first one being a positive, meaning we've identified a genetic cause or a genetic diagnosis for that person's hearing loss. We can also get a negative genetic testing result, meaning we tested these particular genes and we didn't identify a genetic cause. Important to remind families and providers that having a negative genetic test result does not rule out a genetic cause of hearing loss. It could be that maybe our test wasn't able to detect the type of change that that person has, or it was in a gene that hasn't yet been identified. That's the cause of their hearing loss. We have a third type of category that kind of falls in the middle of these. This is our uncertain or inconclusive results. It could be that with an uncertain result, we found, or the lab found a change in one of those genes, and additional information or data is needed to understand, is this the cause of hearing loss in this individual? Sometimes those results mean that they make recommendations for testing other family members or doing non-genetic testing like testing with imaging or things like kidney workup, etc. Sometimes people will ask too, well, what's the chance that I do this testing for myself or my child who's deaf and I get a genetic diagnosis? And overall, the chance is about 40 to 60%, depending on what kind of study and study population you're looking at. But you can see on the graphs here that the chance of that diagnosis or that diagnostic yield does differ by certain characteristics like the inheritance, age of onset of hearing loss, and severity. In knowing some of the statistics and information about genetic causes of hearing loss, you might wonder, well, why, or maybe why not, would people consider genetic testing for hearing loss or deafness? And from looking at the literature, some reasons why people might choose to do genetic testing for hearing loss could include just really wanting to have an answer to help them move from here's our why and move to that what's next part, to get some information about what to expect for that hearing loss, to inform decisions for communication options, and to feel just better prepared about what's going on. Maybe that's to inform future medical care or discuss the chance of hearing loss in other family members or in future pregnancies. But families can also, and we can consider why families might not choose to pursue genetic testing. Maybe they're saying, well, I know it's not a 100% chance we're going to find an answer with testing. Maybe we get limited information, we get a diagnosis, but it's a relatively new described condition, for example. Perhaps we get one of those uncertain results, or we have concerns about the way that that information could be used in a discriminatory way. Also, relevant for this population, maybe there's concerns about, well, could this genetic diagnosis change the way that myself or my child feels about their hearing loss or their deafness or their cultural identity as deaf? Finally, things like cost and the fact that we just can't predict everything with 100% accuracy can also play a role in this decision-making process. And I think I'll just briefly say for when a genetic evaluation for hearing loss could be done, there's a whole bunch of factors that influence when could be the right time for a person and their family. But I remind you and remind other providers that a genetic evaluation can be pursued at different points along this person or family journey. That could include the time of diagnosis for hearing loss or hearing loss in more family members, or really could come down to when that person or that family is ready to have that genetic evaluation. And finally, I'll just briefly touch on, because I know there's some folks, I think it's later today or maybe tomorrow, talking about service delivery models, but how might a genetic evaluation for hearing loss happen? There's my timer. How might this evaluation happen? And they could be done in person or via some type of telegenetics. And I'll point out too that these hearing loss evaluations um, can be done with a genetics provider or specialist, like a genetic counselor or a geneticist, or a non-genetic provider, or some combination of the two. For example, I work with an otolaryngologist or an ENT. On the telegenetics side, that telegenetics appointment could be done either I'm doing it as a member of my institution, or there are a number of companies that can provide that service and contract maybe with your local institution or your local ear, nose, and throat office. With that, I'll just highlight the slides are available for you. I put a number of resources in there to help you start this journey if you're interested or you're working with families who are interested. And I'll just highlight a few of these quickly that there's a pocket guide that's available for you to download with this QR code. It includes all the information we covered today in a handy short little pocket format. A number of great hearing loss and deafness organizations, and some key articles and websites. With that, I am just so excited to know what kind of questions you guys have. And I want to say thank you to the organizers, to my colleagues near and far, and to the patients and families I get honored to work with. So thank you. Looking forward to those questions.
Thank you so much, Amanda. You have a bunch of questions
Good.
lined up for you. So let's see. I saw them coming in, and then when we changed screens, they kind of left me. Here we are. Okay, so the first one is so interesting to see the pattern of hearing loss on the audiogram diagram respective to the genotype. When, how long ago was this correlated?
Oh, it probably totally depends on the gene and when the gene was found. So the example I had for WFS1, which causes that low frequency or upsloping audiogram, I'm not going to remember what year it was. It's one of the first first described hearing loss genes. So that's been established for a while. But there's still more work to be done in this area. And it's something that myself and my colleagues here are interested in, better describing that for all of the genes that we know about, because we know ultimately um, having that information allows us to give back what the expected is to patients and families who get those diagnoses. Um, and on the flip side, even when you as a provider are looking at those audiograms, right, it's exciting to be able to recognize WFS1 being a great example. Oh, wow, when I look at this hearing loss result, this is the gene in particular I'm thinking about, and kind of provide that in counseling anticipatory guidance that this might be the gene that's the cause.
Okay, great, thank you. And I forgot to remind everybody that doesn't know, please click on your questions tab so that you can put your questions in there. But we do have lots of great questions, so I'm not sure we're going to get to all of them. For non-syndromic adult onset progressive hearing loss, does genetic testing provide guidance to prevent or slow the hearing loss progress?
Oh, such a great question. At this point, for most causes of genetic hearing loss, we don't have a way to prevent or slow down the progression of that hearing loss, particularly for the non-syndromic causes. For syndromic causes, I can think of a few examples, those being conditions that affect metabolism, where knowing about that diagnosis can help direct therapies that sometimes have an impact on hearing progression. We are hopeful, though, that options and trials to address that progression, are something that become available with things like gene therapy. At this point, there's no approved gene therapies for hearing loss, but it's something that we think and hope becomes an option for people at some point.
Can you recommend any national organizations that are supporting caregivers of children who are deaf or hard of hearing?
Yes, and they're available in those resource slides. And I think, Jamie, the PDFs are on the website and the resources. So reference that. I think one that I really like, there's an organization called Hands and Voices that has a lot of great things on their website for caregivers of deaf and hard of hearing children. They have a lot of more regional groups for Hands and Voices. I know there's a very active group in Iowa where I live that provides support and that connection to other families, which is really important. But check out those resources for more.
The next question is, even if genetic cause isn't suspected, isn't it recommended to perform gene testing as there could be a new variant in the family?
Yes, so it's kind of a two-part question. So the current guideline does say that if there is a deaf or hard of hearing infant or child, a genetic evaluation can be offered. And that is regardless of if there's a family history or not. And the second part that this person I think is asking about is, could there be something new in that person? And in genetics, we call that de novo, a new genetic change, not something passed on. Absolutely. And that is something you might not know, maybe going into a genetic testing. Is this something that's a new change in this person? Or is it something like that recessive pattern we talked about? I have two hearing parents, and because it's recessive, a deaf or hard of hearing child.
Thanks. So when a child fails a newborn hearing test, is it your experience that all of those families are offered genetic testing upon auditory testing confirmation of newborn hearing loss? If not, why, and should those families be offered that universally?
Oh, what a great question. I'd say, and I can only speak to my experience, and then I'll briefly talk about some of the literature. That no, it's not the case that that recommendation is made universally. And there's trying to think which study to highlight here. A number of studies just to ask the question of when that recommendation is made, who makes it, when is it made, and what are the factors that influence if the person or that family takes that referral. And so I know in the hearing loss space, I know of a few studies that have looked at the role, like, for example, of audiologists who discuss genetic referrals and discuss that this is something that's recommended. And in those studies, they talked about because families are seeing their audiologists so often with their, in this case, we're talking about newborns, that's a very trusted relationship. And that's something where families are more often, if it's discussed with their audiologist, to go to that genetics evaluation. So I think in short, it's a complex question to ask just because there's so many factors to think about. You know, another factor I haven't mentioned of, well, what's the access, right? Part of this conference is to think about what services are available. How far do families need to travel if they need to travel? Is there someone who has expertise in hearing loss that they can speak with for that genetics evaluation? So it's a complex topic, and I think something even outside of the hearing loss deafness space that genetics providers are thinking about.
Thank you. Next question is, do you know the additional yield of a whole exome sequencing or whole genome sequencing after a non-diagnostic panel in this population?
Also a good question. So there have been studies that have looked at the use of exome. I'm not sure I know of any with genome. It doesn't mean they don't exist. After a hearing loss panel, from what I can recall, the biggest increase in yield is going to be individuals who are suspected to have that syndromic cause of hearing loss. So you could consider children who have hearing loss and kind of a multi-system disorder. There's lots of body parts involved, maybe physical differences. The yield might be higher at this point in exome. And in fact, the 2022 recommendations say for those children, we have enough data now that says you should start with an exome for that population or consider a genome at some point. As far as individuals who are suspected, or it looks like they have that non-syndromic hearing loss, from what I can recall of the data, the yield is actually around the same. What will be interest between the exome and the panel will be really interesting to see because one of the differences between a panel and say an exome or genome is with an exome or genome, you could reanalyze the data as we find more genes. So one of the interesting things as we watch maybe this population of people with hearing loss, they had an exome, it's negative at this point. What will it look like in 5-10 years from now? And might that additional yield become evident at that point? I'll be interested to see what happens.
Likewise. So even if genetic cause isn't suspected, isn't it recommended to perform gene testing as there could be new variant in the family?
I think that's probably similar to one that was asked earlier. And that's the reminder too that the recommendations and what we know about hearing loss in terms of family history, the recommendations say if the hearing loss is there, offer the genetic eval, regardless of family history.
Thanks. Can you briefly share your thoughts on a diagnostic workup for a childhood onset unilateral hearing loss, single-sided deafness? Is it the same or different from a workup for bilateral hearing loss?
Oh, such a great question. And oops, I put a bonus slide in here if y'all wait with me while I find it, because I figured I might get this question, but didn't have time to put it in the slides. So as I get the slides up, we know we had talked about that diagnostic yield with genetic testing, or when we do genetic testing, what is the chance we find a diagnosis? And one of the factors that influences that is the hearing loss unilateral 1 ear or bilateral 2 ears? And we talk about a little bit in the ACMG guidelines that got published, and then I put another paper in here that specifically addresses this topic. at this point, when we look at a child who has single-sided deafness or hearing loss in one ear, it's really to take a sequential approach. For everybody, you need to do a physical exam, that family history and medical history as your first step. And if there is suspicions from any of those pieces that there could be type of syndrome for that individual, then genetic testing should and could be offered for that individual. And most of the time, that might mean that they get some type of exome or genome sequencing, depending on what the syndrome suspected is. But we know of a large number, and I suspect this person is asking about people who have hearing loss in one ear where we don't see any differences on a physical exam. There's nothing in their medical history or family history in terms of those referral red flags. And we know from looking at data that, again, depending on what study you look at, when we do a hearing loss gene panel, the yield is like somewhere between 1 to 5% of a diagnosis. But if you look at testing for congenital cytomegalovirus or CMV and or imaging with the MRI or CT, there's a finding in about, again, depending on the study, 30 to 50% of people. So a much higher chance of seeing something with the imaging or the CMV testing. So our group in general follows a sequential, we do the physical exam, family history, medical history, and then discuss imaging or CMV testing if they're at an age where that can still be done. And then for some people, if we still have nothing to explain it, we can consider genetic testing, knowing that much like we can see with any genetic testing, we still might not get a genetic diagnosis. And I can't remember if I put this recent paper in the references, but I can sure add it so you guys can reference it.
Thank you so much.
For more information, visit mountainstatesgenetics.org/contact. This activity was brought to you by Mountain States Regional Genetics Network. Please enter this code in the evaluation survey in order to claim Genetic Counseling CEU GS23-03.